Your timer. Okay.
Welcome everyone to today's program. I am Emily Rapley with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. T. Scott Law, CPA, is the founder and CEO of Zotec Partners, an industry-leading medical billing and practice management provider. Scott founded Zotec in 1998. He is specialized in revenue cycle and practice management in all specialties the company services, and leads Zotec in providing the best technology and solutions for its clients. Zotec Partners is the Indianapolis-based industry leader in specialized medical billing and practice management services for the hospital-based specialty market. Zotec Partners is committed to the continual pursuit of excellence in the physician revenue cycle management industry by delivering effective solutions through its innovative technology, personalized service, and measurable client results. Currently, the company serves more than 8,000 physicians in all 50 states. It is now my pleasure to turn over the floor to Scott to begin today's presentation.
Thank you. Thank you very much. I appreciate everybody joining today. I'm excited to walk through some of the industry changes and all the information that we have seen from a data perspective and how it can impact our everyday lives, as well as more strategically how it can impact industries. From an overall perspective, I wanted to go through some of the objectives of my conversation today. It's obviously to define what is a common phrase of big data. I want to walk through and analyze what big data's role is in healthcare specifically. Talk a little bit about some of one of the biggest trends in healthcare today with big data is the high deductible health plans and the impact of that, and how we can use data to help us navigate the waters of the high deductible plans. Learn how to best use our data in not only in the early initial phases of the data, but also in the longer term trend aspect of things. Consider the patient experience and what data can do from a mining of that data in order to make sure that the patient has the optimal experience. Talk through some of the hospital relationships and the strategies. Just from a disclosure perspective, we work for physician practices that are either owned by hospitals or independent practices. So we have a unique perspective sometimes on how to work with the hospitals in a constructive, collaborative way, and we want to talk about some of those relationships and how data can help with that. And then we want to explore kind of the business intelligence capabilities that are contained in data that comes naturally from the transactions that are either the clinical side or on the financial side, which is what more of our focus is involved with. So with that, I guess from a definitional perspective, it is a very common phrase that gets thrown around a lot, and I like to talk about what exactly big data is. Right now, today, companies create 2.5 quintillion bytes of data per year. It's a huge number of data information, data bytes. That number looks sort of like this, which is a little bit bigger than the national debt number, but it's an amazing number from when you start to look at how you make that actionable data on an annual basis. Interestingly enough, you talk about changing times. 90% of that world's data has been created in the last 2 years. So you can see how we survived for a lot of years with regards to small data. And then now there's just been an onslaught of accumulation of information, everything from your cell phone to your cars and everything that you do is collecting data points that can be impactful for businesses that take advantage of that. Today, I want to talk a little bit about the organizational impact of big data. Like I was mentioning before, the 90% of that data has been collected in the last 2 years. It's almost a socialization of the organization that has occurred with regards to the way the organization has to use that data. It has to be very mindful of the fact that used to be basically there was personal or team accountability in an organization with no data. So you trusted your gut to make decisions, or you knew the business inside and out, and you would be able to make decisions that basically were very impactful. And then you had a degree of personal accountability for that decision. So, careers were won or lost based on small little things that were made just based on your gut reaction to things. In today's world, it seems to have the Google effect, which is basically what that to me is basically when you're sitting in a conversation, no longer does somebody not know the answer, because you can Google it and find the answer no matter what. So what used to be a convincing argument, or you had to think a lot more about why things were, now it's just instantaneous. You can Google it and create a Google effect on your organization. What that means is basically, you move from that gut or that accountability organization to an organization that, if you're not careful, will be all the way over to the other side of the pendulum and be, the data made me do it kind of organization. And this data, using data in a scientific approach is okay, but what has happened is that we transitioned from using data or decisions based on the gut and based upon the entrepreneur or the business manager in regards to that. So now we've moved into this where we're relying heavily on not only the data, but the very scientists who put that data together. And so their perspective gets bled into the conclusions that get made. And if you're not careful, you can have a completely different answer based on the science, just depending on the programmers that are doing that data analysis for you. And there's a lot of evidence that we're starting to see the payoff of big data, is not quite there yet, and it is an elusive thing. It's certainly, organizations get to be in a hurry. They want too much too fast, and they create big bureaucracies around the technology folks that are accumulating this data, instead of necessarily focusing on the folks that are necessary to run the business or to run the service that you have, whether that be a clinical operation, whether it be a financial revenue cycle operation, no matter what process you go through. So it's very important that you take a good look at the impact of these kinds of things on your organization before you embark on any kind of big data strategy, and make sure that the data strategy doesn't get ahead of the objectives of the organization. So that's my preamble or warning for everybody when you start down these paths with data. What does the healthcare data, or what does healthcare do with the big data? Obviously, everybody has heard for many, many years the clinical documentation can provide a wealth of information. From an overall clinical perspective, you can look at larger trends. The claims data is also a wealth of information, and we're going to talk a little bit more. My focus is going to be of today's conversation is going to be a little bit more on the claims data side of the equation and how that can impact the clinical experience. But the whole goal of any data exercise is to take the best of these two data spheres and come up with actionable data. And I don't know if you guys have heard of TAE, which was Microsoft's attempt at Twitter to basically have artificial intelligence put into the tweeting world. From that perspective, TAE in a matter of a couple of days became a Nazi, a bigot, and a supporter of Donald Trump. And Microsoft decided that the actionable data from the intelligence was not something that they would want to promote and continue. So at this point, TAE is in a perpetual service mode. So that's one example of where the data mining and the data learning of machine learning can really get away from you. And obviously, from a Microsoft's perspective, the impact of that is going to be pretty significant. So what is actionable data? And the actionable data, I think, gets broken down into two different scenarios. There's long-term, which in the health world would be behavioral change and population health. I'm looking at large blocks of demographics and understanding what the long-term effect of impact of certain treatment plans, protocols, outcomes, all those kinds of studies are longer term in their nature. Then there's short-term actionable data. So what I call this is the negotiation data, that you can basically negotiate whatever the situation you're trying to do, whether it be a payer contract, whether it be a negotiating for an ACO to take on capitation programs. No matter what you have to negotiate, you can use this data to negotiate short-term conclusions, whether it be financial from a historical perspective or from a personnel perspective. Are the physicians in the practice producing what they should be producing? Are there outliers of coding? Are there outliers on denials, on carriers, and the way that carriers interact with our organizations? So from that perspective, that's really more of the focus of, I think, actionable data in the short-term side of the equation of today's talk, but there is definitely actionable data that has to come out of that and be more in the longer-term mindset. So what I'd like to do is kind of break down and walk through some real examples of data that we're experiencing and using, and from a radiology perspective, we do a lot of radiology practices. So I use the radiology practice as a practice example, but this can apply to any procedure volume that you have in the healthcare space. So let's just take a typical radiology practice. They have 300,000 procedures per year, which generates about 250,000 claims per year. And in order to file a claim, there's about 350 data elements that have to be accumulated. So you can see real quick how a single radiology practice of 300,000 procedures can produce 87,500,000 pieces of data that could be used or evaluated in that whole flow. And that is obviously a significant amount of data. But when you couple that with about 5 practices that also have that same amount of volume of data, now you start to get some actionable data that, because it spreads across a plethora of opportunities or practices in that side of the equation. So let's just take 4 practices that will generate about 350 million data elements per year. And then what do we do with those data elements, or what kind of data elements are we talking about? So you have social data, you have demographic information, which can be tied to census data. You have GPS data based on the availability of their phone numbers to find out their social buying patterns. You have clinical data. Obviously, the reports from the radiology procedure have to be documented. Those contain a wealth of information that is unstructured data, usually. Then you have buying patterns associated with the individual patient, when they like to pay their bill, when they like to shop for their food, where they shop for their food. You have industry data associated with what the social economic industries are in the area. If there's large employers in the area, the impact of the large employer on the industry, and of course easily readily available census data. So you can bring all of those things together underneath one data warehouse to start to really get a feel for what kind of information that you can stratify into those actionable data items that I spoke of earlier. So let's take a look at what all that data could. One example would be the propensity to pay. And what you would do is you basically bake in a series of decision trees that go through and say, here's my insurance percentage. This is the missing information. If it's bad insurance information, and then I go through the decision trees and I can stratify the data into actions using a decision tree metrics like this to get into just one little subset of the data that I spoke about earlier. So then what the idea is to take this data is to understand that this is called a lift chart, and what it does is it tells you the amount of lift that you can get by stratifying data into statistical conclusions, and to get to 100% you know, is obviously the goal. So if you look at the green line, that is the shortest path to 100% of whatever it may be. In this case, it's a propensity to pay, to evaluate the direct correlation of the demographic information to the propensity to pay. And it's not the propensity to pay general credit, but these are specifically propensity to pay healthcare specific bills, which are completely different because, you know, with the FICO scores not being affected by healthcare information anymore, you know, the impact of that, you have to basically, as a healthcare provider, understand your own propensity to pay a healthcare bill versus propensity to pay your car bill, for example. And the red line represents the amount I guess, you know, if you went through a model and you would try to model this data, what are the conclusions that you can come up to get to the green line, which is the perfect scenario to get to 100% within one standard deviation. So in this particular case, I could do 20% of the effort, basically, if I had a perfect model of predicting what to do and still achieve 100% of the result. And that's what this lift chart shows us here. Let's go through some real examples, I guess, of the impact of the high deductible plans. As most people know, the impact of the high deductible plans has you know, taken this industry over the last 5 years by storm. We have seen a 360% increase in the deductible amount, and for the first time ever in the history of the healthcare, you know, we have seen the average deductible, which is now in 2015 was $1,200, has surpassed the average cost. This is a cost based on the high or per belly button actuarial cost of $1,094 based on studies from the Kaiser Family Foundation. And you can see that this break-even point where what has happened is basically the shift from the insurance companies has been to move the insurance risk associated with healthcare coverage down from the insurance company to the patient's responsibility. And if you start talking in terms of what the impact of that is basically we've transformed this business, which used to be a physician to a carrier relationship, into a physician to a patient or a consumer relationship. And this shift has occurred over the last 5 years. And so what that does is it basically forces consumers to do what consumers do. And consumers want to have that kind of Amazon or that Uber or the Google search experience with their healthcare. And the industry has been playing, you know, catch up simply because that shift occurred so fast, and the consumer was previously basically the patient, but not really involved in the financial or the consumer transaction nearly as much as they are today with the trends in the high healthcare. So what we have done is use big data to understand, you know, you used to have to understand a carrier. So you had a profile on a carrier that, you know, you knew how to file claims with that carrier. You knew how to transact in an EDI that helped the transaction sets, would help us with how to interact with the carrier. But now we're in a completely different world. We're interacting with the patient personas. So there's different people. There's a person who has a trust relationship with their physician, and they trust anything that comes from the physician. There are people that have a skeptical relationship, and they know technology very well. So like a Tom, who's a 32-year-old African-American person who is in the technology industry. Or you have the family that is using the same device across the board on the family side of the equation. So all of these items go into calculating the person that we're actually dealing with so that we know how to best interact with that person. And then what we do is we customize based on each persona a technique to using the data and the experience that they want to have to decide how to collect their money. So in one of the profiles, we might have a text campaign that basically starts with a statement via the text message, a friendly reminder, a second reminder with a phone call in there, and ultimately to collection to write that person off if they don't want to pay their bill at all. But before you even get to this point, you can use the propensity to pay with the persona to understand what your efforts should be on a patient-by-patient basis which gets blocked into large categories of data so that you know exactly how to follow up on that particular type of patient. And then you can customize your text messages and your text interactions based on those personas. So the idea here is not to show you the best way to do all this stuff, but it's to say that you should be mindful of who you're dealing with on a patient-by-patient block so that you can basically customize that patient experience and get the best results. So it's not only just the propensity to pay the bill, it's also the propensity to complain. So if a patient group or a block has got a large propensity to complain, the juice might not be worth the squeeze with regards to going after them with a hard collection techniques, because that's going to basically skew your overall complaint process from the hospital and the quality measures that you're getting with regards to that. So when you're out there predicting what you're going to do with this information, you have to also think through the entire transaction and the impact on your entire organization with regards to just these items. And obviously, with the large change in deductible plans, the thing that we're seeing is an increase in bad debt expense. And the idea is to use the data and the techniques to get to the people that you can collect 100% of the collectible money from, and then realize quickly on the bad debt items, then get those written off and out of the process, because it's simply not going to result in any kind of positive experience. Okay, so let's walk you through another example. How to use your specific data. We have some of the information that we pulled together. We wanted to show you some examples of a portal usage by age. And there's a lot of misnomer about the use for Medicare patients, so whether they'll use technology or not. Some of this is a first cut at some of the stratification of the data and how that impacts there. So we see basically a 10% utilization by people over 65 of a portal or website internet traffic. The industry would suggest that that's a little higher. There's payment method. It's interesting that people who are over 65 actually still like to write checks, manual checks, and send them into a PO box, for example. From an IVR perspective, the utilization of an IVR system, the older folks over 65 actually love to interact with the IVR because they feel like they're in control of that situation. So if you have an overweighting of they pay on manual checks, and what you can do with this data is obviously stratify that information into how it works for your particular experience. The other thing that we feel is very important in evaluating is the propensity for friction. Friction is a term that we've coined. Basically, anytime there's an issue with getting a clean claim in the system, paid and adjudicated appropriately, versus any kind of change that has to be made in that particular encounter. So if for example, a patient has an inbound phone call, if the patient has if the payer doesn't pay exactly what they were supposed to pay, if we had to refile the claim because the claim file got lost by the payer, if there's a bad address information, that the patient provided bad address information, or the registration process resulted in bad address information. If there's a request for information back to the provider to clarify coding, for example, that is a example of friction. And obviously the big one is if the claim was denied when it shouldn't have been denied. So we take a look at all of these items and we come up with a calculation of friction. And what we're doing here is basically taking across the healthcare continuum the patient personas that I mentioned earlier, their friction percent, the portion that they represent or that they get involved with regarding their contribution to the friction, the carrier persona. So are they an electronic carrier? Do they have a large propensity to deny claims, inappropriately that we have to follow up on? Is there a percentage of allowed that they pay? So, for example, there's really ways that you can identify that this is a high deductible plan by looking at the percentage of the allowed that the carrier pays, and looking at that as a friction opportunity or a way to craft your experience with regards to the patient. So in that particular case, it's a high probability that you're going to have to pay the deductible, so that from that perspective, you can start to communicate and educate the patient right out of the gate. So at time of service, you can send them a text message thanking them, telling them we're filing to the insurance company, and giving them a heads up that the claim will be ultimately most likely your responsibility. And then there's a physician persona, and this physician persona is got a lot to do with this encounter. If the physician is in the exam room and doesn't necessarily understand the insurance process, but makes a promise to that patient, unbeknownst to anyone involved in the process, that can be something that will have an impact on that person's friction, or the friction that gets introduced into the process. Their denial percentage based on documentation, their scores on audits. The specialty makes a difference as to what specialties are focused on by the carriers. CPT codes that are used. If they use new codes and innovative medical practices that haven't been codified yet, that can have an impact on the amount of friction that's going to be involved with that particular provider. And then their ICD-10 history and the patterns of overall level of coding and their accuracy of their documentation. So all of this goes into what we call the probability of friction, and then you craft paths to eliminate that friction in any way you possibly can. Sorry, I had to take a sip. The propensity for friction it also goes to the ultimate amount that the patient is going to pay, and so there's a upfront estimation can be done, knowing that for example, using some of those data from the previous screen to calculate that entire upfront experience. I think I mentioned some of that. So there's the payer's payment percentage of allowed. There's the reminder, or the remaining portion that is going to be the patient's responsibility, and how that is going to be impactful from the patient's persona to that particular person. The responsibility as a percentage of allowed makes a big difference on that side of the equation. And then there's the overall propensity to pay. So if we can predict using the data to go through a calculation that says this person is 95% of the time they're going to pay a high portion of the allowed amount, is going to be a guarantor responsibility. So let's say that's $500. And then the propensity to pay is based on social economic income and based on their propensity to pay calculations of a whole different set of factors. We can combine the two to come up with a propensity to pay that is for that particular patient. And then you have to put in there's social economic data, and this is where some of the art meets some of the science. Then they have to be willing to pay their medical bills. So and what I'm getting to is the customization of this whole process can be down to the point where we offer payment plans or we offer discounts for paying right up front for people that are going to have a high probability to pay, but they don't really have the money to pay. So then there's the correlation there of the two. And then there's prior changes, prior charges and collections. So these are just some of the data elements that we use to calculate the propensity to pay. And then we marry that up with the likelihood of their balance. And then this shows you kind of the stratification of all the data elements relative to propensity to pay. These are the most statistically significant portions when you go through and break it down into the guarantor propensity for payment. And then it comes out with a mathematical calculation, a formulaic based on, for example, if you take the first one across the top, an anesthesia, an emergency anesthesia procedure, a Medicaid patient, and you can get off to the right-hand side, and you can see that there's a 1.05% likelihood that you're going to get payment on that money. But in true self-pay money, down here where the patient has paid before and they have a payment history with us with regards to that. We have a 90% payment. So you can't just go in there and write off all your self-pay money or outsource your self-pay money to a collection agency. That would be, you know, kind of a large scale, you know, mistake not using this data to come up with a propensity to pay. So there's a subcategorization of each one of these areas based on using this large data to calculate that. And you can see the propensity to pay percentage is a little higher. Okay, and then this shows you some of the data around the friction elements that I was talking about earlier. So you can take this information and you can look at the amount of payments that you get as a result of this friction or after this friction is introduced into the process. And you obviously want to keep that friction percentage as low as possible, but it's important to be able to track this information, and then you can calculate how the impact of making a change in, for example, registration process or cross-referencing of carriers can make a huge difference in this refiling of claims. You can look at claim rejection rates and what are the claim rejection rates with the carrier. The 271 eligibility checks. Why do I have to have an eligibility check if I can do this, you know, and reduce the friction associated with the eligibility items. Okay, so let's go into kind of the hospital relationships that we see, and this is, you know, again, really from our perspective, we see a lot of variations of hospital relationships. We work with large hospital institutions as well as, you know, the small independent radiology practices or the small independent emergency departments. So from that perspective, we wanted to talk a little bit about how this information, for those of you who are on the call that are on one side or the other of that relationship, what can happen. Obviously, the evidence-based information that's out there, RVUs are a great way to basically take the modality mix or the procedure code mix out of the equation and put it into a relative value. There's specialty services that there's turnaround times, and there's departmental insight as to where the patients are coming from and things like that can help a hospital relationship if you're an independent physician practice. The referral patterns and how can you influence those referral patterns are data opportunities. Clinical outcomes is obviously something that working with the hospital to track quality outcomes as well as clinical outcomes, and it may require some extra work on the physician side of the equation, but it's incredibly valuable information if it can be garnered from the physician relationship. Department workflow, and then the overall patient experience, and that comes from either surveying the patients or seeing the patient's experience based on how they're interacting with your overall hospital relationship. There's you know, a lot of discussion about value-based payment models, and if the physician and the hospital are not aligned because they feel like that there's a lack of collaboration or that they don't want to share the information, I mean, this is I'm strongly encouraging the physician groups that we represent to work closer with the hospitals to share their information. There's a lot of resistance in the institution to not share and cross-pollinate each other's databases and things like that. You know, we feel strongly that the only way to make these value-based payment models work is the sharing of information freely between the organizations. Now that takes structure and understanding at a detailed level, but if that effort is put in, it certainly will pay off in regards to that. And some of the examples of paying off, you know, are marketing. Obviously in where the referral patterns are coming from, but it's also what are the marketing campaigns that are most effective. And you go back to the comments about the personas. You can use the persona data, the census data, the per capita income data to grow your organization wisely into areas where you're not only are you going to get reimbursement, but where are the employers and the large contracts so that you can attract those employers to your facilities. Another example, or we have several other examples of business intelligence technology and data that we use. The physician scheduling and productivity is a way for us to basically know by shift or schedule which shifts are producing a profit. I know that's sometimes a dirty word in healthcare, but it makes a contribution to know that what you're working on is producing either a profit or a contribution to the overall organization that you work for. And then you can drill it down to find your largest location group, your place of service, and the time of when those services are there, so that you can staff more appropriately during your peak hours of your patient volumes. And this is a simple use of basically data that's resident already in your claims data, because we need, for example, the time of service. We go down to data service and time of service, because a lot of times the carriers will deny because it same data service without the time. So we put the appropriate modifiers on, and so we use that time, and then we can calculate down into the exact shift that time was done. There's physician benchmarking. You can benchmark physicians straight up against other physicians in the practice. But what's also interesting is looking at overall the national information to look at where you stand from a productivity perspective against the peer groups of radiology practices, in this particular case, nationwide on a work RVU basis by an individual doctor, so that you're basically telling them where they stand, and you use the competitive spirit of the physician to want to be, in the top echelon of any of their peers. Another example is this is we're seeing with high deductible plans, time of service reporting. So from a gross charge perspective, how much of that is basically going to become the guarantor responsibility, and should you collect that information and that money up front? So the guarantor responsibility on this particular practice is got $334,000 of guarantor payments have been collected. $699 was the ultimate guarantor responsibility, and it came at, I'm sorry, I said that backwards. The time of service payments were $197,000 of it was collected of the $699. So there's an opportunity for a practice to collect more of this money up front relative to the guarantor responsibility. And obviously being able to estimate and explain that to a patient of the collected upfront, or set up a payment plan upfront, is a trend that is happening with all of our practices and all institutions that we're seeing. Then there's the effectiveness of the actual payer. We can see how much they pay of the time of the individual allowed amounts, and then there's a effectiveness trending with regards to payers as well. You can also track data on charge creation lag. There's a data service to the data of load, or the data of getting to your revenue cycle organization. There's also then the load to creation time. How long does it take if you have an organization that codes the procedures and gathers all the other 350 data elements, the demographics and all that stuff, pulls it together? How long does it take for that to become a claim that goes out the door? Those are important statistics to track for overall operational sides of the equation. There's a concept called practice controllable denials. So you want to understand this information on a great deal of the patients and why the patient was ineligible for the services and it wasn't checked before they registered, for example. There's new patient qualifications that weren't met, and that results in a denial. There's missing or incomplete invalid treatment and authorization codes. These are all examples of friction that gets introduced into the process at the lowest levels, but they can all be discerned from the high-level data that you can have at your fingertips relative to your organization. And then we talk about front office registration and accuracy. These are things that are very important to friction. If we have to change insurance companies or insurance information, a high propensity of the time, that's going to add friction, cause delays, cause patients to be involved, and it creates a frustration from the patient's perspective on the overall experience because they think they provided it at the time that they were seen. And you have to weed through all of the details and get to individual locations are not as good at being trained and being up to speed on how to enter that registration information. It's extremely important from the billing side of the equation, but an overall data trend that we're seeing is and tracking is the change rates by institution. Okay, another one would be to what you can draw from the data and the practice demographics. There's claims, EHR, and physician scheduling. Obviously, that we talked through that. The staffing, physician productivity. These are all things that we think are very, very important from a big data perspective brought down into a local operational, actionable data opportunity. And then we have taken one more example of how we've taken data and turned, big data into a story. So we basically have created narrative descriptions about practices using the data that is mined from our opportunity to turn that into an actual story that gets told to the physician group or to the business office, in layman's terms, using technology that basically creates that narrative with trends and information that is not necessarily noticeable to the naked eye. So from that perspective, it walks through that, and that's another. It's probably more of an uncommon or unthought of use of big data. But if you can actually create a narrative that people can take actions on, or the story comes to life in a lot better way through these narratives than it does by them being data engineers and having to go through the algorithms and calculations and all of the statistical variations that come along with that. You just tell me what I need to do. No, and that's what this narrative does from a data analytical perspective. So with that, I kind of wrapped up my planned discussions, and now we can take questions or open it up for the questions.
Thank you, Scott. That was a very informative and enjoyable presentation. So as Scott mentioned, we will now begin the Q&A portion of the program. As a reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Scott will attempt to answer as many questions as he can during the last 15 minutes or so that we have for the Q&A. So Scott, to start off, for our first question from the audience, what investments do health systems need to consider in order to interact with patients and improve communications or collections?
I didn't hear the first part of the question. I'm sorry. What investments in systems?
What investments do health systems need to consider in order to interact with patients and improve communications and or collections?
Well, first, I believe that you need to embark on knowing your patients. So the gold is in the mind, and the gold is the data of the patient experience over the last however many years you want to go back. And what that will do is that will point you in the direction of how to interact with those patients better. And that's kind of the personas that it is a statistical calculation, and it is statistically, validatable information to understand the patients. Then once you understand how they want to be dealt with, you have to remember they're the consumer now. They will do everything that consumers do. You want to be able to, they're going to complain, they're going to want discounts, they're going to want to interact with you as friction-free as possible. We even evaluate, if it's below $50, basically there's no friction involved, that patients will pay that, is what we see. If it's above $50, then I have to have a completely different experience with that person. I've got to have that trust relationship and all the investments that can be made there. So to break it down into tactical steps, you need to be able to it's kind of like running a dime store. You got to make dimes on every interaction that you have. You have a text message capability, you have a phone call capability, you have a statement, a snail mail capability, and then you have to have a internet portal presence that can drive people to the portal if they don't have any of the other contact information. And so that would be investing in all of those systems. If you imagine that you guys have gone from the wholesale business to you're now in the retail business, you need a point of service kind of retail minded approach, only you don't have a real store, you have a virtual store. So anything that you make in the investment to the virtual store, I think would be a wise investment at this point.
Okay, thank you. So for our next question, how has ICD-10 impacted big data, and how can we use it for population health management and revenue improvements?
I don't really think any one data element like ICD-10 has impacted what you can statistically garner from things. Obviously, the level of specificity, but it will in fact be probably more meaningful once it gets what I'll call fully adopted. Right now, the adoption from 9 to 10, there's a lot of one-to-one crossovers. There's a lot of acceptance of get it in the family, and we will evolve that over time. So I think that's one area that over time we'll get more specific. Where it's really going to impact us, I believe, in a year or so, is in the denials and what the carriers do. The carriers will be using that information as providers, and I'm an advocate for providers. So from that perspective, we are tracking that like a hawk to see the denial patterns relative to ICD-10 versus ICD-9 codes. So those would be areas that I would be worried about and focused on using big data to help you basically tactically combat the onslaught of denials that will inevitably be coming.
Perfect, thank you. So for our next question, Scott, you mentioned healthcare bill payment defaults not being included in the FICO scores. Could you elaborate a little more on that mention?
Yeah, the FICO scores they weight differently the medical bills, and they do not count against you like they used to count against you. So if you had a practice that would go through the collection process and get obviously you can get to the point where you get liens on people's houses. That lien is still going to be an effective tool. But what's not as nearly as effective is their credit scores will not be as impacted by medical claims. So if the SIC code of a healthcare provider gets weighted down significantly in the FICO score calculations.
Okay, thank you. So we have a few more questions from our audience, but just a reminder, you can submit any questions you have by typing them in the control panel in the space that's labeled Enter a Question for Staff and clicking Send. So for our next question, what data should we collect to measure our quality improvement, and how can we report on those metrics?
Well, quality improvement is a very important area. I think you can measure. There's a it's people, process, and technology. So if you measure the people side of the equation with regards to the quality, that's the most important. What tools are available to measure the people or the quality measures? Obviously, the by user results speak for themselves. We have a complete quality assurance program, for example, on our coders, and we go through and we go by coder, by modality, or by their expertise to code, and then we audit it. So it's the old-fashioned way of auditing that. We are experimenting with machine learning capabilities that will predict a coder's ability or the quality to be basically highlighted, that this most likely is going to result in that being a bad situation, whether it be that they don't have the expertise to do the job that is being done or not. Then there's patient surveys, patient satisfaction surveys. There's a lot of rules with regards to using patient surveys outside of the in examination or the encounter. has the patient given consent to use their phone numbers to do a survey? The laws around that are starting to crystallize, and I think that the patient satisfaction surveys are simply a huge collection data point that we look to use with all of the other features of that transaction. So it's important that you not only look at the scores by themselves in a vacuum, but you relate those scores to what the circumstances are, for that particular persona or that particular patient demographic, so that you get it broken down into why are these people complaining, one example would be that we're seeing complaints of Medicaid patients. If we interact or try to collect they came in as Medicaid, they weren't qualified, and we try to collect that money. Well, that tends to, from a population perspective, lead to a lot more complaints. They escalate things. They just, I don't know whether it's that they don't have the money or the financial class of whatever it is, but there's a high escalation of patient complaints relative to those other factors. So if I did a general population survey, you might look like you have a lot of complaints, but when you break it down into the data that's really generating those complaints, then you have to take different kinds of actions. And that's, I hope I answered the question, but there's a lot more to that quality measures that you can put in place.
Perfect, thank you. So we have time for about one more question. An audience member would like to know, how about monetizing data that a practice possesses? Is there a market, and do you recommend it?
For an individual practice, to monetize data is probably, I think that you'd be hard pressed to do that, especially given the 2.5 quintillion bits of data that are out there, and everybody's scrambling to try to find a way to monetize data. What I do believe in is collaboration and comparability. If there are organizations that you want to contribute to your data to, your claims data to, but even claims data is only part of the equation, and that's a lot of people have claims data. What puts a company like Zotec or companies like that in a unique place is that we do 70 million transactions a year. So, I mean, multiply that data across every social demographic information class in the country. So you can look at that, and that becomes actionable, significant, statistically valid data. Otherwise, a individual practice doing that, I think it'd be hard pressed to get to the statistical significance. But I obviously don't have all the answers for what the individual practices are able to do.
Perfect.
I'd much rather see the practice, rather than monetize it, actually use it. Because if you use your data for your practice, for the betterment of your practice, that is more valuable than what you could sell it for. Believe me.
Well, that makes a lot of sense. Thank you, Scott. It looks like that's all the time we have for questions today. Before we wrap up, I just want to thank you one more time for your excellent presentation, and to all of our audience members, thank you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.
Thank you.